I'd like to thank my distinguished colleague, Dr. Chu, and the other organizers of the meeting for the opportunity to speak with you today on lessons learned from the pandemic, the Johns Hopkins experience with focused on immunocompromised patients. My disclosures are shown here. I am an investigator on studies supported by industry, but I receive no personal financial remuneration. I will mention off-label and EUA emergency use authorization uses. And I want to thank particularly Dr. Brian Garibaldi from the Johns Hopkins Crown Registry, Dr. Dori Segev, Dr. Brian Boyarsky from the Johns Hopkins National Solid Organ Transplant Vaccine Study for the kind loan of their slides. Throughout the talk, I'll use the abbreviation SOT to mean solid organ transplant. So what have we learned during the pandemic? First of all, where are we with the US COVID experience overall? As of September 13th, 2021, we've had 41 million cases in the US, 660,000 deaths, 380 million doses of vaccines have been given, translating to 178.7 million fully vaccinated, 1.78 million have received a third dose of mRNA vaccine since August 13th. 53.8% of the population is fully vaccinated, and that includes almost 65% of those 18 and over, and 82.5% of those 65 and over. And this shows you the waves of COVID cases in the US over time between January 2020 and mid-September 2021. So now I'd like to turn to the Johns Hopkins Crown Registry, and I thank Brian Garibaldi for about the next 10 slides. Basically, this is built on the precision medicine analytics platform created at Johns Hopkins for collecting and analyzing large data sets, translating research into clinical interventions using digital tools, and then measuring the impact of research on clinical practice. The Johns Hopkins Crown Registry consists of patients across the Johns Hopkins Health System in 5 hospitals who've had a positive test for SARS-CoV-2 or a diagnosis of COVID-19. It uses data from the electronic medical record EPIC, including labs, medications, vital signs, notes, radiology, and physiologic monitoring. It took many, many people to build this, and there are many projects going on using these data, using various novel statistical analytics. Now comprises 7,500 COVID inpatients, 80,000 COVID outpatients, and 300,000 negative controls. And this shows you the number of COVID-19 positive patients in acute care and in the ICU over time. And one of the initial publications from this group was looking at patient trajectories among persons hospitalized for COVID-19, a cohort study using the Crown Registry, and individual patient trajectories in terms of cumulative incidence of severe disease and death are seen over at the right. This enabled them to create what they call SCARP, or Severe COVID-19 Adaptive Risk Predictor, basically knowing certain predictive variables. One can calculate the risk of severe disease and death using vital signs, respiratory parameters, laboratory parameters, comorbidities, and demographics. And just to mention a couple of different applications of this is Elisa Ignatius, one of my infectious disease colleagues. And as you know, it's been a quite mixed literature on tocilizumab in terms of its benefits and outcomes. However, in the Crown Registry, in this early cohort, this is before the large-scale use of dexamethasone after publication of the recovery trial, it does appear that tocilizumab is associated with reduced mortality in this cohort. And also, in this cohort, tocilizumab did not lead to increased infection risk in terms of many particular infections, bloodstream infections, urinary tract, pneumonia, and so forth. And then also the group looked at remdesivir and found that in this cohort, it was associated with faster clinical improvement, 5 versus 7 days. However, it did not show improved mortality in patients receiving remdesivir. So the take-home points from this precision medicine analytic platform is that prediction modeling can inform clinical trial design. Real-world data can provide information about populations not represented in clinical trials, and phenotyping patient subgroups can suggest therapeutic targets. So that's work that's really going on at Hopkins overall, and many, many subspecialties are now using these data to look more closely at their own patients. I'd like to turn now to solid organ transplant recipients, a group very close to my heart. There have now been many single center and a number of multi-center retrospective studies I'd like to cite this one. This is our colleague Olivia Cates in infectious disease, who started this out of University of Washington. It now comprises over 1,000 solid organ transplant recipients at over 50 centers. At the time of this publication, it was 482 SOT recipients, about 2/3 kidney or kidney pancreas, and the others of other types of transplants. Of these, 78% were hospitalized, 31% required mechanical ventilation, 20.5% died by 28 days, and this has been a relatively consistent figure of mortality over multiple centers and studies. They found that age, congestive heart failure, lung disease, obesity, lymphopenia, and abnormal chest imaging were associated with risk for mortality. Immunosuppression was modified in 70% of these patients. In the vast majority, it was discontinuation or reduction of the antimetabolite, mycophenolate or azathioprine. However, multiple measures of immunosuppression intensity did not show an increase in mortality. This was an early group of patients in whom many received hydroxychloroquine, only 2.9% received remdesivir. Of course, we no longer use hydroxychloroquine, and now this is reversed, and many patients receive remdesivir. 13% of this early cohort received IL-6 or IL-6 receptor inhibitors. Now I'd like to turn to our Johns Hopkins COVID experience in solid organ transplant, and a lot of this is the work of analyst Teresa Po-Yu Chang. Basically, we've been fortunate in seeing a low mortality, less than 6% of solid organ transplant recipients hospitalized at Johns Hopkins, whereas most other series have shown a 20% mortality or higher. We're not entirely sure why this is, but the main elements of our management have been holding mycophenolate in virtually all of these patients while continuing prednisone and tacrolimus. We administer remdesivir and dexamethasone for hypoxemic patients if they meet our center criteria. And we've used convalescent plasma quite frequently because we feel these patients don't mount much of an antibody response. Monoclonal antibody therapy has been very valuable for mildly ill outpatients, but under current EUA is not used in inpatients. It has prevented a lot of hospitalizations, we think. We'll talk more about that later. We've used empiric antibiotics frequently because bacterial secondary infections are common. We've checked fungal biomarkers, and we've treated aspergillosis in the setting of COVID early and aggressively. We monitor CMV DNA in these patients, and we give 3 months of acyclovir prophylaxis if they've received dexamethasone to avoid late fulminant reactivation of herpes simplex and varicella zoster virus. And also with Teresa Po-Yu Chang and the Epidemiology Research Group of Organ Transplantation, we've looked at inpatient COVID-19 outcomes in solid organ transplant versus non-solid organ transplant patients using the Crown Registry data. And basically at the time we initiated this, which was August 2020, there were a few studies that had directly compared SOT and non-SOT. And we had the advantage, as we mentioned before, of this precision medicine analytics platform that was available to us for this analysis. So we compared 45 hospitalized solid organ transplant recipients versus 2,427 non-SOT patients who were admitted with COVID-19 to our healthcare system up through August 2020, about a year ago. We evaluated hospital length of stay and inpatient mortality using competing risk progression. We compared trajectories of WHO COVID-19 severity scale using mixed effects ordinal logistic regression, adjusting for severity score at admission. We found that SOT and non-SOT patients had comparable age, sex, and race. However, SOT recipients were more likely to have comorbidities such as diabetes, hypertension, HIV, and peripheral vascular disease. We found no statistically significant difference between SOT and non-SOT in the maximum illness severity score, the length of stay, or mortality. And the severity score on admission was slightly lower for SOT than non-SOT, perhaps reflecting the fact that transplant patients are in close contact with their transplant coordinators, and we have a relatively lower threshold to admit them. Median duration on oxygen therapy was similar. The nadir absolute lymphocyte count was lower in SOT, and the peak C-reactive protein was lower in SOT as well. Despite a higher risk profile, SOT recipients actually had a faster decline in disease severity over time compared with non-SOT patients. In other words, they got better faster. This shows you the WHO severity scale on admission in the first 2 bars here, and the maximum achieved during admission, which was not statistically significantly different between the SOT and non-SOT. And this shows you the non-SOT patients in blue and the SOT patients in yellow, the mean of daily WHO severity score throughout the admission, again showing you that SOT recipients start out pretty close to the non-SOT, but they do get better faster as measured by the severity score. At all times, however, the absolute lymphocyte count was lower in the SOT patients than the non-SOT patients, as you see here, yellow being SOT and blue being non-SOT. And so in conclusion for this portion, patients receiving a solid organ transplant did not necessarily experience worse outcomes than non-SOT patients hospitalized with COVID-19 in our healthcare system. Despite having more comorbidities and being on immunosuppressive agents with discontinuation of mycophenolate, SOT patients had no increased mortality and in fact had a more rapid decrease in illness severity. We concluded that longitudinal trajectories of clinical courses and lab values can yield insights beyond aggregated outcomes, and the transplant community should be aware that SOT status does not necessarily portend an adverse outcome from COVID-19. I'd like to turn now to COVID-19 vaccination in solid organ transplant recipients, and these are studies done by the Epidemiology Research Group in Organ Transplantation under the direction of Dori Segev. I'd like to thank Dr. Segev and Dr. Brian Boyarsky for the slides that follow. And again, this is a very large and talented group of people who are doing these studies. There are many more that I could not fit onto this slide. This is a prospective cohort study that we started back in December 2020 with online enrollment that was approved by Johns Hopkins IRB, subject to local IRB policies. We were looking at two main things. One was safety of the vaccines, local and systemic adverse effects, looking for rejection or neurologic or infections, and immunogenicity as reflected in serial anti-spike protein antibody measurements. We currently have 4,708 participants enrolled across the US, of whom 2,600 are kidney recipients, 1,103 are liver recipients, and the rest are divided between other types of transplants. This was specifically designed to have no in-person study visits because both of wanting to streamline a large study during the pandemic and also to protect patients from the necessity of healthcare system contact. And the design of the study is really quite simple, as you see here. There are safety questionnaires at different times. There's a baseline antibody test. And then anytime the patient gets a COVID vaccine, which the study did not give them, but followed them whenever they got a vaccine, antibodies are obtained at 1 and 3 and 6 and 12 months after that. And we used two different platforms. One was the Autoimmune anti-SARS-CoV-2 ELISA, and this was done by, as you see in the upper left here, a home blood drawing device where patients could obtain the blood themselves and mail it in. The other was the Roche Alexis anti-SARS-CoV-2, and this was drawn at one of the branches of the national lab called LabCorp in the US. Both of these correlate quite well with neutralizing antibody capacity. And then there have been a number of papers published from these data so far. This is just a brief listing of them. We'll go over some of these in more detail. Basically, in terms of reactogenicity, it was pretty similar to the general population. There was no excess of rejection or neurologic issues. There was a slightly higher tendency to systemic reactions in younger patients, but overall mild to moderate, not severe, very similar to general population. And then immunogenicity after the first dose was pretty poor. Only 17% of SOT recipients mounted an antibody response after dose 1. And lower antibody response was associated with being on an antimetabolite, mycophenolate or azathioprine, as part of immunosuppression. Lower antibody responses were also associated with older age. And interestingly, those who received mRNA 1273 or Moderna vaccine were more likely to develop an antibody response than those receiving Pfizer. So you might ask, why report the results after 1 dose? Well, because at that time, there was some discussion in some countries of whether COVID vaccine should be spread out among the population more, with people each getting 1 dose in order to have more vaccinated. But we felt that this strategy for solid organ recipients would be suboptimal. Now, fortunately, the dose 2 data are improved, although not anywhere near 100%. So we saw overall antibody responses in 54% of organ transplant recipients after dose 2 of mRNA vaccine. And again, older age, shorter time from transplant, receiving Pfizer rather than Moderna, and being on antimetabolite immunosuppression were associated with lower responses. Interestingly, and this is a theme we see now across multiple centers and multiple studies, if the patient had an antibody response to the previous dose, they were more likely to have a strong antibody response to the next dose, as opposed to those who had no antibody response after the previous dose. And of patients receiving antimetabolites, only 8% responded to both doses. 35% had no response to dose 1, but responded to dose 2, and 57% still had no response after 2 doses. We've now extended this to over 1,000 patients, and so we've identified 3 phenotypes: the negative non-responders after 2 doses, the negative to positive weak responders, and then the positive to positive who do get boosted after the 2nd dose. And this shows you in the pink dots the patients who had no antibody response after dose 1, where they landed after dose 2. And the gray lines show you the improvement in antibody levels between dose 1 and dose 2 in patients that did have some antibody response to dose 1. So you can see the boosting effect there. We have a parallel study in rheumatology and autoimmune patients. Interestingly, their antibody responses were overall better than in SOT recipients, with 74% having antibodies after the 1st dose, although those receiving mycophenolate or rituximab were less likely to have an antibody response. Safety was consistent with the general population. There was no excess flare of autoimmune disease noted. And 2nd dose results in over 400 patients showed 94% had antibody responses, although those on rituximab still had poor responses, with only 26% having antibodies after dose 2. And we now have some emerging data on the 3rd dose of vaccine. Now, in the US, we were not permitted under EUA to give a 3rd dose until August 12, 2021. However, 30 patients in our observational study managed to get themselves 3rd doses prior to that. We did not give it to them, but we did measure their antibody responses afterwards. And of these patients, 17 had received Pfizer and 13 had Moderna vaccine for their initial series. And some received the same vaccine, others received a different vaccine for the 3rd dose. 50 received the Janssen vaccine for the 3rd dose, 10 received Moderna, and 5 received Pfizer. And of these 30 patients, 6 of them had had low positive antibody titers after dose 2, and all of these boosted to high antibody titers after dose 3, again, similar to what we've seen in other settings. But of the 24 patients who had no antibodies after dose 2, 2/3 of them still had no antibodies after dose 3, and 1/3 did develop antibodies of either low or high titer. There was 1 patient who had rejection, but subsequent dose 3 studies by other groups have not found an excess risk of rejection after dose 3, and other side effects were similar to previous doses. We now even have 18 SOT recipients in our study who've managed to get themselves 4th doses of mRNA vaccines. Again, we did not give these to them. A median time of 28 days after dose 3. And it's found that 63% who had negative or low positive pre-dose 4 titers did develop high positive titers. And those who previously had high positive titers had even better boosting of their antibody titers. But still, some did not respond even to 4 doses. We've learned a lot from France because the French National Authority for Health had already authorized a 3rd dose of mRNA vaccine for immunocompromised patients back in April. So this nice study by Nassim Kamar and colleagues looked at 101 SOT recipients who received a 3rd dose of Pfizer vaccine. Of these, 40% had antibodies after dose 2. This went up to 68% after dose 3. And if you had antibodies after dose 2, this predicted a good boosted response after dose 3. However, of those with no antibody after dose 2, 44% still had no response after dose 3. And those with no antibody response were more likely to be older, more immunosuppressed, and to have a lower EGFR, as we've seen in other studies. And this shows you in the left-hand panel the prevalence of anti-SARS-CoV-2 antibodies before the 1st, 2nd, and 3rd dose and 1 month after the 3rd dose. And then you see the actual quantitative titers on the right-hand panel showing that there's definitely a benefit to the 3rd dose, although again, not for 100% of patients. And Benoit Manet and colleagues from Strasbourg, France, using Moderna vaccine 3 doses in 156 kidney transplant recipients, showed very similarly, 49% became seropositive after dose 3. These were patients who were either seronegative or low seropositive before. Of the 60% who were seronegative before dose 3, only 27% turned seropositive after dose 3. But for the 40% that had any level of antibody before dose 3, 81% developed seropositivity after dose 3, again showing that starting from even a low positive antibody, you get more of a boost from the next dose. And we also now have a beautiful randomized trial from University of Toronto of 3rd dose of Moderna vaccine in transplant recipients. So they took 120 solid organ recipients who'd received 2 doses of Moderna vaccine, randomized them to receive a 3rd dose versus placebo at 2 months after dose 2. Primary outcome was an anti-receptor binding domain antibody of greater than 100 units on the Alexis assay. And basically, they found that at month 4, this level of titer was present in 55% of the Moderna group and 18% of the placebo group, which was highly statistically significant. And in fact, the median percent virus neutralization was 71% in the Moderna third dose group versus 13% in the placebo group. And safety was excellent, similar to dose 1 and 2 side effects. This shows you in the upper left-hand panel the anti-RBD antibodies after the third dose in the Moderna third dose versus placebo groups. And then in the upper right-hand panel, you see the change in titer between before and after the third dose. In the red, you have the Moderna group, and then the blue, you have the placebo third dose group. And then the lower panels show you neutralization before and after the third dose, and they also looked at polyfunctionality of CD4 T cells after the third dose, again showing the benefit to a third dose in these patients. However, as we mentioned, not everyone has vaccine responses. What are the clinical consequences of this? There are now multiple case series of breakthrough infections after vaccination, especially in solid organ transplant patients. This is one by Ali and colleagues from New York University. Reported on 14 SOT recipients who were diagnosed with COVID-19 at a median of 23.5 days after completing their COVID-19 vaccine. Of these, 50% were hospitalized, 36% had severe COVID, and 1 died. So definitely more than mild disease here. Another way to look at it was Brosh Nisimov and colleagues in Israel did a retrospective multicenter cohort study of 17 hospitals and looked at patients fully vaccinated with Pfizer vaccine who required hospitalization for COVID. Out of 152 such patients, they identified 25% who had poor outcomes defined as a composite of mechanical ventilation or death, and 22% who died. Not surprisingly, almost all of these patients had comorbidities, but fully 40% were immunocompromised, which is far higher than the prevalence of immunocompromise in the general population, again suggesting these patients are at higher risk for breakthrough infections after vaccination. And then in our own group, Carolyn Chin and colleagues attempted to pool the data from 17 transplant centers. It's very difficult to ascertain the denominator of vaccinated patients at any given center, but she was able to do this in 18,000 fully vaccinated SOT across 17 centers. There were a total of 151 breakthrough infections, or 0.83% identified. 87% required hospitalization. There were 14 deaths, so mortality in these breakthrough patients was 9.3%. So we compared this to CDC data for over 100 million fully vaccinated adults in the US through the end of April, in whom breakthrough infections were 0.01%. And the hospitalization and death numbers, as you see here, this calculates to an 82-fold higher risk of breakthrough infection and a 485-fold higher risk of hospitalization and death in SOT recipients as compared with the general population in the US. So given that, what are our next steps? We and others are studying potential interventions to improve vaccine responses, looking at heterologous additional vaccine doses of a different vaccine from the original one, possibly modulation of immunosuppression, holding or reducing mycophenolate if the transplant team agrees to that. We're very excited about upcoming clinical trials of monoclonal antibodies for pre-exposure prophylaxis in vaccine non-responders. I'll describe that more in a moment. And we do tell all of our transplant recipients to continue all safety measures and not assume that they're protected after vaccination. And in conclusion, for the vaccine portion of the talk, antibody responses after 1 dose of mRNA vaccine are suboptimal and improve after dose 2, although still only 40 to 54% after dose 2. These improve further after dose 3 of mRNA vaccine, especially in those with previous antibody, but there's still patients without detectable antibody. Other responses such as T cell immunity, memory B cells are under investigation. Antibody responses in patients with rheumatologic diseases are overall better than SOT, but those on rituximab are still unlikely to mount a response. We didn't have time today to talk about oncology, but it turns out that antibody responses are better in solid tumor patients as compared to hematologic malignancies and are especially low in chronic lymphocytic leukemia and non-Hodgkin's lymphoma. In patients with stem cell transplants, antibody responses are better if they're more than 12 months out from the transplant, if they have a higher lymphocyte count and they're off immunosuppression. We do endorse COVID vaccines for immunocompromised patients, including third doses where authorized to give them. However, breakthrough infections occur in fully vaccinated immunocompromised patients and are sometimes severe. Studies in progress should help us define correlates of protection, and as mentioned, other strategies may be needed for those who still lack antibody responses, and immunocompromised patients should definitely be included in future clinical trials of vaccines and therapies. Before closing, I'd like to say a word about monoclonal antibodies. This has turned out to be one of our most effective therapies and really the only effective therapy outside of clinical trials for outpatients. The US FDA initially gave an EUA for bamlanivimab, which we don't use anymore, casirivimab, imdevimab, which has emerged as the most frequently used monoclonal. For a while, we used bamlanivimab, etesevimab, and most recently, sotrovimab received authorization as well. These do produce reduction in hospitalizations if they're given early, within the first 10 days of symptoms, to outpatients with mild symptoms who are not hypoxemic and who have risk factors for progression to severe disease. The rise of viral variants has the landscape, and that bamlanivimab and bamlanivimab etesevimab are now no longer useful, unfortunately. And now we also have a recent EUA for post-exposure prophylaxis with casirivimab and imdevimab for household contacts or people living in congregated settings. And there are now some emerging papers on monoclonal antibody utility in SOT patients. These two early case series demonstrated that patients receiving monoclonal antibodies did very well in terms of not requiring admission, not requiring supplemental oxygen. In our own study here at Hopkins, this is Willa Cochran, who's our transplant infectious disease nurse practitioner. She has organized a nurse and NP-led initiative to refer solid organ transplant outpatients rapidly for monoclonal antibody infusions. And with excellent outcomes, 30 or 34 of these patients did not require hospitalization. We've now sent probably over 50 for this therapy. And again, we think this has made a big difference in their outcomes. We also do close home monitoring for SOT outpatients with COVID. We send them free pulse oximeters in the mail and do frequent televisits. And Dr. Veronica Diverti, my colleague, and I have also now used this combination of casirivimab and imdevimab on emergency IND plus off-label remdesivir for some severely B-cell depleted patients who have SARS-CoV-2 that they cannot clear even after 2 months. They remain actively infected, although they don't have severe respiratory failure. They're unable to clear, have a low cycle threshold, and they're at risk for transmitting to others as well as remaining ill themselves. So our first such patient is a bone marrow transplant recipient who had graft versus host disease on prednisone and ibrutinib, could not clear symptomatic COVID for over 2 months, but when we were able to get casirivimab, imdevimab on EIND and off-label remdesivir, he did clear, and also his neutropenia and chest CT findings resolved. Subsequently, we've treated 7 patients on this protocol with good results. So conclusions regarding monoclonal antibodies: the ability to treat early has improved outcomes for SOT recipients, has helped to prevent progression to severe disease and hospitalization. Post-exposure prophylaxis is now permitted under EUA and needs wider utilization. We're excited about pre-exposure prophylaxis, and we'll be starting clinical trials of this soon. And this will be for highly immunocompromised patients who don't mount antibody responses after dose 3, or who are severely B-cell depleted and not anticipated to mount response to any vaccine. And our investigational use of casirivimab and imdevimab plus off-label remdesivir has cleared some virus for some patients with active COVID for over 2 months. I'd like to thank my colleagues in the Epidemiology Research Group in Organ Transplantation with Dori Segev, Director, and our Johns Hopkins Crown Registry team with Brian Garibaldi at the head, and our Transplant Center and Infectious Disease and Transplant ID program with Kieran Marr as Director. Thank you to Dr. Chu and the other organizers of the meeting, and to all of you, thank you for your attention.